Good afternoon, everybody. Thank you for being here. Welcome to the, I think this is the 10th Lipson lecture. 11th. Okay, thank you. My name's Joshua Hare. I'm the director of the Stem Cell Institute. I'm very pleased to be here to introduce the lecture. The lecture is named after Arthur E. Lipson, who was a well-respected CPA in South Florida for many years. He was my patient, and he had end-stage heart and kidney disease, and he was very committed to supporting research in both of those areas. He was an active philanthropist, giving to many causes in the Jewish community, ranging from education to medical foundations. And in 2014, they gave a wonderful gift to the Stem Cell Institute to foster research in the regeneration of the kidney, which continues to this day. A portion of that gift was earmarked to initiate this lecture. And as I said, we are now in the 11th year of that lectureship.
Our speaker today is Dr. Bonventre. He is the Samuel A. Levine Distinguished Professor of Medicine at Harvard Medical School and is Chief of Renal Medicine and Founding Chief of Engineering and Medicine at Brigham and Women's Hospital. He previously served as Director of the Harvard-MIT Division of Health Sciences and Technology. His research focuses on kidney injury and repair, with particular emphasis on inflammation, translational biomarkers, and stem cells. He discovered kidney injury molecule KIM-1, a urinary and plasma injury and prognostic biomarker, and identified CRAB-A domain's role in transcription inhibition, a core component of CRISPR-I technology. He has developed protocols to convert human stem cells into kidney tissue. With over 450 original publications, 155 plus chapters and reviews, and 3 books, his work has been cited over 96,000 times with an H-index of 155. He is a member of the American Society for Clinical Investigation, the Association of American Physicians, and the American Institute for Medical and Biologic Engineering. A past president of the American Society of Nephrology, he also co-founded the National Space Biology Research Institute. He has received numerous honors, including the Homer Smith Award, the Osler Medal, Bywaters Award, and the Massry Award. His NIH-funded research has earned him 2 merit awards from the NIDDK. He has also served on the NIH-NIDDK Advisory Council and is the editor of seminars in nephrology. Please welcome Dr. Bonventre.
Well, thank you. It's a pleasure and an honor to be here to speak to you today. I'm going to talk about kidney injury and repair, and I'm going to hopefully present this in a way that there'll be a little bit for everyone, because I know that there's a very diverse audience here. What I won't talk about very much or at all is actually stem cells and the work we've done on organoids, since that's a little bit more specific for this more general talk. So here are my disclosures, and to a large extent, they relate to activity with patient safety and also trying to basically be innovative in terms of therapeutics for kidney disease. So I'm going to talk about, as I said, basically various aspects of kidney injury and how the kidney repairs itself in an adaptive or maladaptive way. Starting out with how do we best identify injury to the kidney? And then later on in the talk, what are the primary pathophysiological contributors to the injury and implications for treatment approaches? And then how does the kidney repair itself in an adaptive way? And why does the repair process become maladaptive in many cases? So first of all, this is a plot of the world in the context of the incidence of AKI, acute kidney injury. For those of you who have been around for longer periods of time in medicine, this is the term which I'll talk about a bit also, which is the old term we used was acute renal failure. It's acute kidney injury. In studies of hospitalized patients using a KDIGO definition. KDIGO is a kidney disease to improve global outcomes. And I'll mention KDIGO a couple of times because it's an international collaboration to basically improve kidney outcomes. And here you can see that in North America, in studies of hospitalized patients, the incidence in particular in ICU patients is quite high. And that goes across the world, to varying degrees. And in many of the cases where the incidence is low, such as Northern Africa, that's probably related to the fact that the documentation is not quite as great. But this is, as you all know, a very important disease process. And the KDIGO definition of acute kidney injury, it's defined by a serum creatinine rising by a greater than or equal to 0.3 milligrams per deciliter in the measures that we normally use within 48 hours, or serum creatinine rising greater than 50% or 1.5-fold from the reference value, which is known or presumed to have occurred within 7 days. So a little squirrely here, presumed to have occurred. But in any case, this is the definition. And then there's a third component of it, which is a urine output less than 0.5 mLs per kilogram per hour for greater than 6 consecutive hours. Now, many people who are diagnosed with AKI don't have urine output being measured. And this third term is really relevant to the ICU setting, where there's hourly measurement of urine output. Okay, and where did this definition come from? Well, a number of years ago, Glenn Chertow and David Bates basically put together the Brigham and Women's Hospital experience over a year, and they did a relatively straightforward analysis of looking at creatinines over the span of a year and categorized the changes in creatinine. And so they found, and I was a collaborator with them on this, they found that even a change of greater than 0.3 milligrams per deciliter could result in a significant odds ratio that was adjusted odds ratio for death. And this ultimately led to this study and another study from the Cleveland Clinic that came out a little bit later on postoperative AKI, showing that, again, if there was a change of 0.3 milligrams per deciliter or greater, that had a significant effect on mortality. And up until this time, we used the term acute renal failure. But clearly, these data were interpreted as the fact that you could have acute kidney injury, term using injury rather than failure, as an indicator of the fact that more modest elevations in creatinine could lead to significant consequences. And so there was an acute kidney injury network that was put together within a year or two of these studies. And then ultimately that evolved to the KDIGO definition, which I just gave you. And also basically the situation where now the term of what we were dealing with was called acute kidney injury. There's still a failure component to it if it's very advanced, but essentially this is the history of how things evolved. And so this is another way of presenting it. It was essentially something that was regraphed by another individual for Nature Review Nephrology. And again, it shows that while the incidence goes down, obviously, of an increase in serum creatinine, that the odds ratio for death on the right-hand side here goes up quite dramatically just by being correlated with the change in serum creatinine alone. And as time evolved, it became clear that it wasn't just the absolute value, but the duration that was also important for the definition. So now the akin definition involved 3 different stages, which were, stage 1 being 0.3 milligrams per deciliter increase, stage 2 meaning a doubling of creatinine, and stage 3 being greater than a 3-fold in baseline, 200% increase in creatinine. And so if you looked at any of these stages, but they only lasted for less than 2 days, well, there wasn't much of a change in mortality rate. But if they lasted for greater than 7 days, there was much, and this sort of makes sense, right? Thinking that if it was a short-term change in creatinine, then that would probably reflect a hemodynamic phenomena that was less involving the kidney parenchyma. And the natural history of acute kidney injury varies across the board. For example, in red here, you can go from pre-renal to an initiation stage to an extension stage. These stages are not critically important, but to sort of try to figure out where your patient is, but just more in something. Usually patients are pre-renal for a while. In traditional sort of AKI, ischemic AKI, or even septic AKI, pre-renal for a while, then there's the initiating event often, which then the process extends and you get this marked reduction in GFR. And over time, there's stabilization, and in some cases, you can get a recovery, and that results in no CKD progression. Many patients who develop acute kidney injury, which we'll come to, have underlying CKD. And so even getting them back to normal for them, which may not be a normal renal function, but that's a success story. Basically, there's no CKD progression. But many other patients will have the same sort of drop or greater drop in GFR and never really return to their baseline. And that frequently results then in more progression of CKD over time. The risk factors for acute kidney injury are many, and this is only really a partial list, and I'm not going to go through this since I don't particularly like lists like this. But you all know that the older the patient with diabetes, the individual with underlying chronic kidney disease and cardiovascular disease, exposure to nephrotoxins, the septic patient, essentially any kind of disease setting where, in particular, if there's some underlying kidney history there, they're more prone, the patient's more prone to develop acute kidney injury. But, now we've talked about creatinine. Is that the best way to determine injury to the kidney? Well, it's not a very reliable way. First of all, if maybe I can just come back to this curve. There's a relationship between serum creatinine and GFR, and you all, I think, know this. But if you have to get very low in your GFR when you're clinic patients. The slight increase in creatinine from 0.8 to 1.2 could reflect a halving of their GFR. even though the creatinine is within the normal range. And that's something that I think everybody should really come away from this talk just realizing, because we use creatinine and it's helpful, but it really does not tell the whole story. And in particular, we use normal ranges for creatinine in following patients, and that's basically reassures us, unfortunately, but we may not be seeing a halving of the patient's GFR if we measured it directly. And this is another reflection of this. If you look at renal function over time, if you get kidney injury under, let's say, a normal individual, whether they're in a marathon race or have some mild injury, or you give them a drug like cisplatin, and which I'll come to, and the kidney normally has a renal functional reserve. So the kidney has a lot of reserve, and if you damage nephrons, the other nephrons will respond by functioning better. And so if you really have to basically functionally impair the kidney beyond this renal functional reserve before you get a drop in creatinine. Here is reflected by renal function, where the normal baseline GFR is here. And over time, if you have decreased functional reserve, increased baseline injury, you're going to have much more apparent relationship between the injury and the change in GFR, as reflected by creatinine. So that's important. So if you're seeing your normal patients in clinic and you're measuring creatinine, it doesn't mean that they don't have some tubular injury. They may have had a drug that affected their kidneys. They may have had some other event, or even in the hospital, they may have said, so it's a very insensitive to, looking at creatinine is very insensitive to pick up kidney injury. And this is sort of reflected a little bit by this. These are studies of patients with testicular cancer. So these were young men in their 20s, early 20s. And we just measured the KIM1, kidney injury molecule 1, which I haven't presented yet, but as a marker of kidney injury, as well as N-acetyl glucosaminidase, NAG levels during cisplatin treatments in patients with testicular cancer. And with each of the courses of therapy, there was a significant increase in both biomarkers, which are telling us something about injury to the kidney. And each one, again, each course, there were 4 courses depicted here, and you can see they went up each time. Yet creatinine, serum creatinine did not change. So again, a reflection of the fact that, yes, serum creatinine's an important biomarker, but we need other things too. One of the things that we've worked on is kidney injury molecule 1, which we cloned a number of years ago in mid-1990s. And here we took some post-ischemic rat kidney and compared it to the contralateral. So we did unilateral ischemia to the rat, and we compared we made messenger RNA and then cDNA from both kidneys. And then we used a method which is not used very much right now, but it's a representational difference analysis. I won't go through it. It's a reiterative process to pick out genes that were markedly upregulated in the post-ischemic kidney. And we cloned a few of these and found one that was specifically expressed in the proximal tubule that we were most interested in, since that's the site of injury in the kidney that is reflected by many toxins and ischemia. And, and we cloned this molecule, which is a one transmembrane domain molecule, which is heavily glycosylated and which is cleaved by a metalloprotease and appears in the urine. And so that was one of the things that we wanted. We went immediately from the rat to the human to see if this was going to be relevant in the human, and it was, and that's why we studied it. And then when here's a more recent look at the human atlas and showing different organs and the expression of KIM1, and this one peak is kidney. So the other thing that encouraged us to study it more was that it was unique to the kidney and unique to the proximal tubule. Not entirely true. There's a little bit of expression in other places. But then we did some rat experiments at the time and showed that with cisplatinum, for example, 1 to 2 days after giving cisplatinum, which you know is a still commonly used cancer agent, there was an increase in KIM1. Since the baseline was so low, these changes were quite dramatic. They were more dramatic after 3 or 4 or 5 days. But they were also at a time when there was no change in BUN and no change in creatinine. Again, which is consistent with this story that if you look at BUN and creatinine, you would ultimately see the toxicity, but you wouldn't begin to see it until 3 days, whereas here you saw it at 1 day using this marker. And more recently, in some great work that's being done at Harvard with these collaborators, Sandro and Ji Yun, they're basically taking human biopsies and setting things up where, now you do a section, you do staining to evaluate a human biopsy. They've worked this out so that you can use 10 different antibodies on a single section. And we convinced them to look at KIM1. And here you can see this was a patient who had a podocytopathy, so minimal change disease, kidney minimal change disease. And the pathology report, which is also insensitive for proximal tubule injury, showed a diffuse podocytopathy on electron microscopy, but the proximal tubules were read as mild tubular dilatation, focal brush border loss, and an isolated mitotic cell. Okay, so not very much from the pathologist, but look at the staining for KIM1 in each of these proximal tubules. Again, a much more sensitive marker. And then, so now historically, I'm talking now going back after, this is a recent analysis in a human sample. And then what we were involved with, we got asked to be involved in this consortium, nephrotoxicity consortium, because they found at the time that KIM1 was a good marker. And essentially, this reflects the work of 20 pharmaceutical companies. Most of this was done by the pharmaceutical industry as a pre-competitive study because they wanted to get better markers for toxicity. And essentially, all the rats had histology scores from 0 to 3. And so this summarizes it. This is an area underneath the curve from an analysis where the area underneath the curve being 1 is essentially an ideal biomarker with high sensitivity and high specificity. And you can see that KIM1 performed very well here, maintaining this sensitivity and specificity, even when the histology was very, very low, even when there was very, very little histological changes. And at that time, when there were very few histological changes, the BUN and NAG, N-acetylglucosaminidase, were not very good markers, and serum creatinine was almost useless. If the area underneath the curve is 0.5, here it was about 0.6, but 0.5 means completely random. So again, and this was reinforced in studies that we weren't involved with by the European group and published later in the same year, where the area underneath the curve was quite high, close to 1. Compared to other markers, clusterin, which is a good marker, lipocalin, which is a good marker, but not very good. This is NGAL, not as nearly as good as clusterin and KIM1. And here, serum creatinine, the European group, had an area underneath the curve of 0.54, which again is close to 0.5, which means that it was completely useless for rat studies trying to predict nephrotoxicity, which is very important for drug development. And so so ultimately in 2008, it was qualified by the FDA, not alone. There were about 3 other biomarkers, including clusterin, that were qualified for proximal tubular injury by the FDA and the European equivalent. And as a safety marker, as a preclinical safety marker when assessing kidney toxicity of experimental drugs. And the FDA actually published this. We weren't co-authors on this. They published the utility of regulatory applications that came in that referenced KIM1. And then in 2018, it was qualified by the FDA as part of a composite in phase 1 clinical trials to evaluate nephrotoxicity. And this is the composite. So clusterin, cystatin C, KIM1, NAG, NGAL, and osteopontin are now used. They're qualified by the FDA, and they're used pretty extensively in phase 1 studies to look for nephrotoxicity in early clinical studies, and in some extent in later studies, phase 2 and phase 3. Okay, so what are some of the primary pathological or pathophysiological processes that are contributing to injury? You can hear me still? Okay, sorry. So again, although there's been some controversy about this, this was a publication that we had from the New England Journal probably 25 years ago now. And it just reinforces the notion that from a clinical point of view, it's very good to look at kidney injury from a pre-renal, intrinsic renal, and post-renal perspective. And then the intrinsic renal perspective can be primarily tubular, interstitial or vascular or glomerular. And the tubular components, have to do a great deal with ischemia or sepsis and toxins. So generally, approaching a patient with this relatively simple perspective I find is still very useful. So I'm going to go through a number of things now. Just a number of years ago, we looked at the effect of sex on propensity toward acute renal failure and found that female mice are much more resistant to ischemia. Here's creatinine clearance. We actually measured the creatinine clearance in these animals, and you can see 24 hours after ischemia, the males had a marked reduction in creatinine clearance. The females didn't. With 60 minutes of ischemia, which is really quite dramatic, you can see that many of the females survived and most of the males died. And so we did a number of experiments, and I'm not going to go through them all. Our conclusion was that testosterone was more important in the male than estrogen being protective in the female, but it wasn't completely, there were still effects of estrogen in the female. But we did orchiectomy in the males, and we actually were able to protect the males with orchiectomy, and taking the intact females and giving them testosterone, basically markedly changed their effective susceptibility to injury. And that's been found in actually a more recent study looking at over 2 million individuals and showing that in humans, there is this relative protection in females versus males, and something that we think may, to some extent, be related to estrogens, but I still think it may also be related to the lack of testosterone in females. But that's sort of somewhat controversial, but relates to the pathophysiology. So in thinking about the kidney injury and what's going on from a pathophysiological point of view, there's a healthy kidney and an injured kidney. So with an insult, either due to a nephrotoxicant or ischemia, there's tubular injury, obstruction of the tubule with debris, endothelial cell activation, leukocyte recruitment, and vascular injury, which overlaps with the endothelial cell here. And this injured kidney then can repair in an adaptive way so that the repaired kidney looks close to the normal healthy kidney. With switching, macrophages play a major role in the injury itself. And if you switch from M1, which are pro-injury macrophages, to M2, which are again, overly simplifying, but M2 are repair and macrophages, resolution of the inflammation, tubular proliferation, cells, and endothelial repair, that will result in a kidney that is adaptively repaired. However, in many cases, there's maladaptive repair, and I'll get into that later. The pathobiology varies. So what's going on in this box varies depending on the location of the injury, glomerular versus tubular versus vascular. You know, whether it's a thrombotic angiopathy with complement very involved, for example, versus which is primarily vascular, or tubular injury, which is with the toxins or with sepsis, or glomerular, which is again thrombotic angiopathy, but many other lupus, many other cases of autoimmune disease or lymphomas or myeloma. There's much interaction between cancer and kidney failure, and whether it's acute and chronic, and whether the mechanism really is primarily an inflammatory one, a mitochondrial injury one, or a DNA damage, or a combination of those. Okay, and another important thing to think about in the context of the pathophysiology is what the anatomy of the kidney looks like. This is a highly schematized cartoon, which really ignores the complicated structures in the cortex and points to the outer medulla, which is a key part of the kidney, where there's a thin, where there's a thick descending limb, which is the pars recto, or the proximal straight tubule, and there's a thick ascending limb. These are transporting structures, and the perfusion is quite dramatic and important. And what happens as blood goes from the cortex to the papilla tip is that there's more hypoxia. So here you can see there's basically a short circuiting of oxygen from the descending limb to the ascending limb. So why is this relevant? Well, it's relevant, I think, in ways that, in particular, if you have edema, many of our septic patients do have, right? In their periphery, we see it. But if these vessels in the outer medulla are leaky, become leaky, and you keep pouring fluid into these patients, then what happens is you essentially stop the blood flow in the outer medulla, because you're dealing with a kidney that has a hard capsule and can't expand. So the other feature of anatomy that I think it's important to realize, and people don't often realize it, is that the models that you see in the kidney of the relationship between the blood flow and the tubule are overly simplistic in all of the textbooks, basically. And so here's a structure of a midcortical glomeruli where the white microfill is filling the convoluted tubule. So here you have a sense of really what a convoluted tubule looks like and why it's called convoluted. This is the beginning of the straight segment. You can see in the background in gray, these are the glomeruli. And you see the blood vessels in gray. You don't see them perfectly here, but bottom line is that contrary to what you see in the textbooks, this proximal tubule is perfused by about 10 different efferent arterioles from 10 different glomeruli. There isn't a one-to-one relationship. Why does that matter? Okay, it matters because in the context of if you have a disease process that affects any one of these glomeruli, you're going to affect the entire tubule. And the glomerulus that the tubule is emanating from may be an entire, sort of a different region of the midcortex or the inner cortex. And this has to do with the way we interpret pathology, because frequently we'll say, or the pathologist will say, well, there doesn't seem to be as much injury here because maybe only 10% of the tissue looks damaged. But again, you'd have to go serially with multiple sections because there's redundancy at the same glomerulus in terms of the same proximal tubule. So, and this particularly has to do with interpreting biopsies from septic patients where it's, for example, was reported in this study, a very good group, most renal tubular cells appear normal. The degree of cell injury and death does not account for severity of sepsis-induced organ dysfunction. So I think that one thinks about the complexity and also the fact the biopsies are in the cortex. So I've already told you that if sepsis involves leakiness of the vessels in the outer medulla, then you're not going to see much injury in the cortex. Okay. All right, and inflammation plays an enormously important role. This is, again, a cartoon reflecting the endothelial cells and the lack of or breakdown of the barrier, the endothelial cells, a loss of some of the glycocalyx in the endothelial cells, an activation of these blood cells that are circulating, increasing the interstitial population. And here's the damage to the tubule, which may be initiating a lot of this. Okay, so again, I'm going to cover a number of things which I think sort of interesting and relevant. So one of the predisposing factors relating to the pathophysiology, we all sort of suspect is relating to dehydration, making the kidneys pre-renal. And this is a recent study just published in Lancet Planet Health, where they did a very large study looking at heat waves of 1.3 million people in the UK and looking at acute kidney injury. And you can see that they found this significant relationship relating the 7-day heat wave in 2021 associated with a 28% increase in acute kidney injury. So volume status is key, not surprising, but this sort of and then this whole issue again, which I think was important, whether you're in the ICU, in particular, if you're in the ICU in your practice, being pulmonologist or anesthesiologist or whatever, if you increase the interstitial edema, you're going to wreak havoc on the ability of the kidney to function. And there's a number of this is just an article from figures taken from this critical care journal showing the effects of fluid overload on various organ systems. And again, you're all sort of familiar with cardiac edema, pulmonary edema, increased venous pressure with renal interstitial edema, decreased renal blood flow, increased interstitial pressure, reduced GFR, uremia, and salt and water retention. So I think this is markedly underestimated and should be incorporated into the general fluid therapy of patients with acute kidney injury. And just I've tried to summarize here from a therapeutic, going from the pathophysiology to somewhat of therapeutics. And fluid therapy is key, right? We're trying to keep the blood pressure up, and frequently then it's a question between vasopressors, vasoactive agents, and volume. And these are some general principles. So oliguria is not an indication for fluid administration. Intravascular hypovolemia should be the only indication. These are not my rules. These are sort of gleaned from consensus groups. And optimal fluid composition has not been defined in general. Then there's the crystalloid, and hyperchloremia being associated with renal vasoconstriction. So there's a good deal of, from the ICU perspective, there's a good deal of discussion about the not giving too much chloride. So buffered solutions are recommended for patients at risk of AKI who are not hypochloremic, rather. And saline is recommended for hypochloremic patients with close monitoring of the chloride. And then in terms of colloids, gelatin-based fluids should be avoided. Albumin does not provide a survival benefit compared with crystalloid. Albumin decreases fluid requirements for resuscitation, but does not reduce the need for renal replacement therapy, and starch should be avoided. So these are general. Okay, now I'll go to another thing, which is timely right now, which is the SGLT2 inhibitors. Since these drugs have been incredibly effective, not only in holding back the progression of chronic kidney disease, but cardiovascular disease of various etiologies. And so this was one study that we did looking at the odds ratio, or looking at the risk of AKI in patients who are on these agents. And this was at a time after the drugs were approved. There was a black box warning with regard to acute kidney injury. So that's why I think it's important in general to know about this. That warning has been taken away now. There have been, in addition to this study, a number of studies here, with diabetes and no diabetes, comparing SGLT2, the incidence of AKI in many trials. And you can see, if anything, the SGLT2 inhibitors protect against AKI in compared to a placebo, and in our cases, even compared to the GLP-1 agonist. Okay, and the SGLT2 inhibitors can affect the hemodynamics and oxygenation by decreasing glucose reabsorption, decreasing energy demand, utilization, increasing oxygen delivery, and increasing tissue ATP. It also, because of the way the drugs work, they'll increase distal delivery, and that will, in the nephron, and that will in turn feed back on the glomerulus to cause vasoconstriction of the afferent arteriole to the glomerulus. The hydrostatic pressure then, or filtration, is reduced, and the GFR is reduced. And the hyperfiltration, which is normally associated with diabetes early on, is also reduced. So yes, the GFR goes down, but I think it's really the consensus now that AKI is actually, if anything, made less common with these SGLT2 inhibitors, and we're studying mechanisms in the laboratory that go beyond the hemodynamic effects on filtration, but effects on the proximal tubule itself, energy metabolism that could help explain this. Okay, and these are other mechanisms. I'm not going to go through all of these, but this is, these are the SGLT2 inhibitors, and these are the different potential mechanisms, including decreasing fibrosis, decreasing reactive oxygen species, decreasing cellular senescence, that could essentially be renal protective and inhibit the AKI to CKD transition. And so another aspect of AKI is the subphenotyping. I mentioned this a little bit early on. And so I said that there's different populations of patients, some of them that will recover, some of them that won't. And so there's a lot of activity. I'm not going to really show the data here, but just to say that this is an example of subphenotyping, a relatively simple example. So you have a heterogeneous cohort of patients. You're trying to figure out who will respond to fluids, who will respond to other interventions. And what you'd like to do is to enrich the population first. And so in this case, this was, or in this study, they've used two biomarkers of, which I think I'll mention on the next slide. They use two biomarkers and say, okay, if the biomarkers are up in the urine, then those patients are at higher risk for AKI as compared to the patients who are at lower risk if the biomarkers are not up. And so then you could basically provide the people at lower risk with standard of care, perhaps some, you can use some adaptive modification like early ICU discharge. And with the patients at high risk, you can implement the KDIGO recommendations and consider other preventive approaches, like, for example, remote ischemic preconditioning or glutamate or other approaches. And the KDIGO recommendation, so again, this is relevant to how we think about preventing AKI in the post-op patients or the dehydrated patients. These are the KDIGO recommendations. Discontinuation of all nephrotoxic agents if possible. Hemodynamic monitoring and optimization. So there's an algorithm. I'm going to show that on the next slide. The details might end up being reasonably obvious to you. Close monitoring of serum creatinine and fluid balance and urine output. Avoidance of hyperglycemia. Consideration of alternatives to radiocontrast agents. Discontinuation of ACEs and ARBs for 48 hours and avoidance of starch, gelatin, and chloride-rich solutions. This is what were the recommendation, and this is the algorithm. Not to remember it, but just say, so this is being tested right now. This is not, what has been shown is that you can select a high-risk population, and that high-risk population does seem to respond to more aggressive therapy. That's been shown. And the therapy does not include pharmacologic therapy because we still don't have a specific treatment that we can take off the shelf and give these patients. We're still very actively looking for that. But this hemodynamic algorithm, looking at passive leg rising, looking with cardiac output, and then doing things along the way. When do you give dobutamine or epinephrine, et cetera, et cetera. So this is being evaluated now. This paper was a protocol paper just describing this multinational study. Okay, the other thing is, well, what about the other therapy that we're always giving these patients, which is renal replacement therapy? And essentially, after all the years of looking at many studies in many contexts, we still don't have increased survival related to renal replacement therapy. We still spend a lot of resources using renal replacement therapy. And so here are the indications for patients with AKI. Refractory hyperkalemia, metabolic acidosis, severe pulmonary edema, uremic complications like pericarditis, bleeding, or encephalopathy. Urgent indications in patients without AKI are poisons, let's say, early on. Non-urgent is persistent severe AKI with blood urea nitrogen levels above 112, oliguria or anuria for more than 72 hours, but this is a non-urgent condition. And then no indications, severe AKI, KDIGO stage 3 in the absence of complications, and sepsis in the absence of complicated AKI. There's been a lot of work on sepsis, and some of you who are in that may have strong biases that there's some benefit to taking out cytokines in individuals with sepsis, but in fact, the studies have not, in general, borne that out. And there are a number of therapeutics that are being tried based on all of the different mechanisms that I've talked about. And there's recently a study in the New England Journal, so it's worthwhile mentioning, that an amino acid infusion was also showed some benefit, statistically significant, not an enormous benefit, but statistically significant. And I think we'll hear some more about this. This was a study that was just published. And then in the last 5 minutes, 6 minutes or so, I'll talk about the repair process. And let me actually go to this slide. So intrinsic, how did the kidney repair itself? Well, in studies that Ben Humphreys and Jeremy Duffield did when they were in the lab, and Andy McMahon in collaboration with Andy McMahon, basically the notion was, okay, we know that the kidneys lose polarity, the proximal tubule loses polarity, there's cell death, there's spreading out of some of the remaining cells, there's proliferation and a return of differentiation. But where are the cells coming from? Are the cells coming from the bone marrow? Are they coming from an interstitial stem cell compartment? Are they coming from the tubule itself in surviving cells or stem cell population? And the bottom line, without going through all the publications, is that they're not coming from the bone marrow, they're not coming from an interstitial stem cell population, and they're not coming from a stem cell population in the tubule. They're coming from dedifferentiated epithelial cells that, in the process of dedifferentiating, then go through cell division. And this cell division can be quite dramatic. In studies that we did many years ago, we showed that we were doing ischemic preconditioning studies, and it's one of the really very interesting things that we've tried to apply clinically. But if the kidney is ischemic for a while and you come back 8 days later, so here's the ischemic kidney, creatinine goes up, come back 8 days later, you then make it ischemic for a longer period of time, nothing happens. And you can actually do this out to 6 weeks. It's less effective as you go along. But the one of the things that we learned, there were many things that we learned from this, but one of the things was that even after one bout of ischemia, there was changes there were changes in the kidney epithelium or the kidney interstitium 12 weeks after a relatively mild period of ischemia. So this showed what everybody was thinking at the time was that there was complete repair, but this showed that there wasn't complete repair. And essentially AKI leads to CKD, CKD predisposes to AKI, And we all know that AKI and cardiovascular disease, or CKD rather, and cardiovascular disease are tightly linked. You know, a 20-year-old with end-stage renal disease has a cardiovascular risk of a 75-year-old without renal vascular disease. You all know that, right? Okay, and then there is this crosstalk with organs. And this was from a New England Journal review, and showing that, you know, acute kidney injury, then over days, months, years, has an effect on cardiac cell apoptosis and necrosis, and then ultimately leads to cardiac hypertrophy and fibrosis. And many of these things that are listed here are same things that happen in the proximal tubule in terms of how cells become prematurely aged, as it were, or you know, how they become hypertrophic and result in cardiac failure. And here's an analysis showing that many studies showing the hazard ratio for chronic kidney disease progression after various levels of AKI. All AKI, just stage 1, which is the relatively mild 0.3 change, or stage 2 or stage 3. In all cases, there's an increased association of progression of chronic kidney disease. Okay, and then as part of the sort of cell biology of this progression, we've done a lot of work on senescence, whereby if there's an increased number of senescent cells after injury, then this predisposes to maladaptive repair. And I won't, okay. So let me then end up here with one linking mechanism of what might be going on in the proximal tubule. After injury, upregulation of molecules such as KIM1, which turn out to be very effective in bringing in albumin laden with palmitic acid. There's lipid overload to the proximal tubule. This overload results in a change in the balance of dealing with reactive oxygen species, DNA damage, cell cycle arrest, and the generation of senescence-associated secretory molecules that end up causing fibrosis. There's also activation of the inflammasome and the inflammatory response. So this is like one connection. And then I'm going to end there and just say thank you to all my trainees. I'll show one slide, and the funding agencies. Here's one slide of about 10% of the trainees over the years. So with that, thank you very much.
Thank you, Dr. Bonventre. Having heard this from a pioneer in the field of AKI, we're extremely grateful for such an elegant presentation. Because of the hour and people have to go to clinic, everyone is excused. Those that have questions, please come forward. I want to remind everybody to check the chat or check the door as you leave for the QR code for MEC and MOC credits. And I look forward to seeing you all next week. Thank you very much.